So when we give a diuretic, when we give a loop diuretic, we're going to mess with what's going on in that loop of Henle. You'll see in the handout it talks about a threshold response phenomenon. So we have to excrete enough diuretic into the loop for it to exert an effect. So once it is reached a threshold effect within, or amount within that loop, then what happens is that the loop cannot do its usual work. So it won't excrete water, water will not exit as much, but the main effect of those loops is here on the ascending. Okay. So if we're going to mess up the ascending loop's job, then what are we going to affect the most? Sodium. Okay. Wherever sodium goes, water goes. Very attractive. Okay. So when we give a loop diuretic, we can help the person to excrete a lot of sodium and water. Okay. That's how we get rid of extra fluid. If the kidneys are functioning poorly, you will see under contraindications that anuria. What would anuria be? Can't produce urine. You can't get the drug into the loop, then you won't get effect. So poor renal perfusion, poor kidney function will usually lessen the ability of a diuretic to exert this effect. For people who have normal kidneys or even just a mild degree of renal insufficiency, these drugs are very effective to pull off fluid.
Does this affect the kidney though? If you review it too much?
Yes, it will, and we're going to talk about that. All right, so that's what I've gone through is under mechanism of action, is we're going to increase excretion of water and sodium. And other electrolytes kind of get hit along the way, potassium, magnesium, and calcium, especially with the loops. And then I talked about under that last bullet above the picture, so reduced response, decreased delivery of the diuretic, increased sodium reabsorption somewhere else in the proximal tubule, or in the other areas under the direction of the renin-angiotensin system or the sympathetic nervous system. Or you get a decreased absorption out of the gut because there's too much edema there. So all of those things can play to the diuretic not exerting itself. If you look on the top of page 9, the drugs that fall into this category are furosemide, it's the most common, it's been around the longest, one that's most commonly used. The other one is bumetanide, Bumex, and torsemide, which is Demodex. Furosemide, again, mostly the go-to. The problem that furosemide has that the others can overcome or correct is its bioavailability is 50%, and the variation in patients is very wide. So why would that make a difference to you? Well, if you've got people who are not responding to the drug like you expect, then one of the things you can do is switch them to one of those other loops. Torsemide has a very long duration of action. Both of them have much more predictable absorption and less inter-patient or intra in the patient or inter-patient variability. So that's one of the places we use that information. If you go down to about the fourth bullet, appropriate use of diuretics is also key to the success of other drugs. If you do not have an adequate diuresis, your other agents like your ACE inhibitors and your beta blockers will not work as well. Okay. So if you don't get enough fluid off, you can get fluid retention. Your beta blockers can exacerbate that. The patient can precipitate heart failure. We talked about that under the arrhythmias. One of the most important things to do before starting a beta blocker was to make sure you had their fluid status stabilized. Get rid of excess fluid. If it's too high, the person can get hypotensive if you diurese them too much. So patients who have evidence of fluid retention need to have adequate diuretic therapy. You can combine it with sodium restriction of 2 to 3 grams a day. How much is needed is not well defined. So you can't rely just on that, and it makes patients' diets miserable. But it's not especially if you've got somebody who's eating a lot of salt-laden products, especially your African Americans, who tend to be more salt sensitive. So getting patients to reduce that amount of sodium is a reasonable recommendation. Again, most common loop diuretic is furosemide. We start with low doses. 20 would be considered a low dose. You might, in an elderly person, even go down to 10, but 20 is usually. And you're going to expect their urine output to go up, right? Weight decrease is generally about 1/2 to 1 kilo per day. We'll talk about why that is the goal on the next page. If you're not getting the response that you want, you can increase the dose. Most people who have normal renal function will need somewhere between 40 and 80 milligrams a day. It's in the handout somewhere. If you're going to change the dose, or if you're going to up the dose before increasing frequency. You'll see patients who are on twice a day furosemide. But it's better to go up on the dose first until you hit maximum and then change the frequency. You'll get better effect. Renal insufficiency, you see there the dose requirement may be 160 to 200 milligrams a day. You will see furosemide or the loop diuretics referred to as high ceiling diuretics, meaning they have a very high maximum dose and you continue to get diuretic action as you increase the dose. So there's no narrow therapeutic range here. It's very wide. So people who reach max dose, then you can consider splitting it. Here, if we told a person to take it twice a day, if we have them take it in the morning and the evening, what's going to happen? They're going to get up and pee all night. Okay? So, advise patients to take it like first thing in the morning, 2 o'clock in the afternoon would be reasonable. So you're not interfering with their sleep. When you get into people with diabetes, it starts to becomes a problem. Is it due to their sugars being high? Is it the diuretic? It will wake them up at night. Is it due to other problems that people have as they get older, getting up and going to the bathroom more frequently? So our goal is to try to get them to a dry weight, to where we've got all excess fluid. So how would we know if we're in a dry weight? Pardon?
It stops changing.
What stops changing?
So don't they start losing weight as you get them?
They will. Okay, so you're saying weight stabilizes. What else?
Weight before
What are your symptoms of volume overload? So pulmonary edema. What else? Fetal edema. So those symptoms should reverse and go back to normal. So their dyspnea should go down, their peripheral edema may or may not go down fully, but those things should get better. They may resolve. Most people are put on a fixed dose, but we also ask them to weigh themselves every day. And we're looking for changes of more than 2 pounds in a day, overnight. That usually is fluid, excess fluid. So then what we may do is give them instructions to increase that dose, or we may add a diuretic that has a different action. So we might add a thiazide. We might add something like metolazone. Different action to boost that up, to get rid of that fluid, get them back to that, whatever you decide is their dry weight. Some patients will be monitored by outside groups, so give them a scale, they'll transmit their weights every day to that group, and that group sends you a record of all of these weights so that you can see it. Okay. So monitoring parameters: weight, resolution of symptoms, so their lungs should get drier, Their peripheral edema should go down. Their JVD, if it was present, should get better, resolve. You gotta look at serum potassium. You have the ability here to get rid of a lot of potassium. So why do we care about hypokalemia? Heart. So it can be arrhythmogenic. So we don't want people to get too low. Rate of diuresis. You can remove too much fluid too fast. And if you do that, the kidneys will tell you, the heart may complain also, because you can't get enough filling pressure. So there is a balance there of how fast. The more edematous someone is, the longer it's going to take it off. We're going to watch BUN and serum creatinine as well. So when we are giving them a diuretic, where are we pulling the fluid from? Vascular space, okay? We're affecting whatever is filtered by the nephron. That's where we're pulling it out of. We're pulling out of blood, okay? Where is there excess fluid?
In the tissue.
It's in the tissue, okay? So you are indirectly pulling. So you've got vascular space. And you've got extravascular fluid. Okay, so as you pull it out of here, we're hoping it comes back in here. Why? How does that happen? It's all that hydrostatic pressure that we talked about, interstitial pressure. So we're trying to get it to move this way. So we've got this in like a third compartment. So you've got to think about what compartments. If you pull it off too fast, then where does the problem show up? What do the kidneys do? Oh my gosh, we don't have enough fluid. So what's it going to do?
Retention.
It's going to try to increase. It's going to if you don't have them on any other drug, then you'll get vasoconstriction and you'll get aldosterone release. Okay? So you got to be careful. So as you're mobilizing that fluid, it will take time. That's why the goal is about 1/2 to 1 kilo a day. Okay? The body can do that pretty well. You may see faster in the beginning, but as you keep going on, you got to slow it down. So you're going to be looking at BUN to serum creatinine. Okay. What is the usual ratio of BUN to serum creatinine? Have you had that yet? No. Okay. Good. Hard to talk about the kidney. Okay, so 10 to 20 to 1.
BUN.
If this goes up, then there's a pre-renal problem. If serum creatinine stays the same. So one of the things we're going to be looking at is BUN, is serum creatinine. BUN is going to go up the longer you go. They'll get more azotemic the more you dry them out. If serum creatinine also starts going up, you've affected the kidneys to a greater degree. So if you look down through there, rate of diuresis, let's see, we talked about if the BUN rises, look at the last two bullets. If the BUN rises and serum creatinine is stable or minimally increases, the patient is volumal overload, then you can continue with diuresis. The BUN will probably keep going up. If the serum creatinine reflects intravascular volume depletion, the kidneys are like, not going to take on any more off, then you reduce the dose or stop the diuretic and let everything equilibrate. So the big takeaways for you right now is that the kidneys are important to monitor when you've got somebody on a diuretic and you're trying to mobilize large amounts of fluid. And BUN and serum creatinine are the big monitoring. They will tell you whether you're taking it off too fast and if the kidneys can handle it. Questions about that? Not a lot of contraindications to the use of diuretics. Anuria would be one. Kidneys aren't working. Can't get the drug into the site of action. Diuretic resistance or refractory edema.
Somebody's getting married?
Okay. Diuretic resistance, refractory edema. Okay, so if you've got significant impairment, it's not bothering me unless it's bothering. Is it bothering you all? Distracting? You're enjoying it? Okay. If you've got increases in angiotensin II or aldosterone, so it could be that they are not taking their other medicines, or you don't have high enough doses of other medicines to suppress those. Presence of hypoalbuminemia. Okay. So if these drugs are highly protein bound, what does that mean? Okay. Back in the vascular space. You got albumin. Albumin has lots of sites where drugs like to hang out. And they'll sit there. They are always in equilibrium with what's free. Okay? What's the importance of the free drug? It's the only one that can move and go into extravascular space. Okay. Where did I say it exerts its effect? Where do diuretics exert their effect? It's how much is in the lumen of the nephron. So whatever moves out into extravascular space doesn't do us any good at all. There's no receptor there. There's nothing there for them to act on. We need to keep it in the blood so that when it gets to the capillaries that surround the nephron, it'll move into the nephron. Okay? So if it moves out into the tissues, doesn't do us any good. So if we don't have enough albumin in the blood, then guess what? Most of it just moves here, and then it moves out into the vascular space. So if you've got resistance and you're not getting the effect of the diuretic you want, you gotta look at their albumin. Okay. Takeaway. If they're consuming large amounts of dietary sodium, perhaps. If they're taking drugs that block the effects of diuretics on the kidney. Prostaglandins have lots of local control. They're like the local sheriff. We've talked about this before. They get to control what's in their district. Okay? You use a non-selective, non-steroidal, it knocks out those peripheral ability to make peripheral prostaglandins. Okay? So people can have, the prostaglandins could be doing a reasonable job in somebody who is tending to volume overload. You knock out those prostaglandins, chaos reigns, and fluid overload becomes the problem again. Okay? So we want to avoid non-selective, we want to avoid non-steroidals as much as possible in people with heart failure. So what can you do? Well, you could switch to IV. You could use an IV diuretic. You could switch from furosemide to one of the other two, either torsemide or bumetanide. You could add a diuretic with a different mechanism, like we talked about, so a thiazide or metolazone, and work on different parts of the nephron so they would have a different effect. And for patients who have systolic heart failure, so which one is that? Is that preserved? Look back at your reduced. Okay, so you can add spironolactone. You can use an aldosterone receptor antagonist. Okay, so risk of treatment with a diuretic. We've already said these. You can fluid deplete them. You can electrolyte deplete them. If they have serious arrhythmias that you're treating, remember potassium and magnesium low what's the problem? What can happen if they're low, if they're on a class 3 antiarrhythmic, and their potassium and magnesium gets low, what are we worried about? Worried about proarrhythmia. Okay, so keep monitoring those. Hyperuricemia, so uric acid levels go up, they could have a gout attack. Photosensitivity, these agents have sulfa-containing groups that sensitize the skin to sun if they're out. Okay, questions about the diuretics? Yes.
You mentioned just real quick that they have sulfa-containing groups. Is that something you need to know about?
Just know that they are photosensitizing. Wherever they complex in the skin gets get in the sun will activate that, they'll have an allergic reaction. Okay, video. So I checked this one, it's still up and going, it's a good one. The next little picture there gives you some of the places, or shows you some of the places where the different diuretics work. So mannitol, that's a more osmotic diuretic, very powerful because it can exert its effects. The further up you can go, closer to Bowman's capsule, usually the more potent the diuretic, because you can affect more sodium excretion. Then the loops, you know about the aldosterone antagonist on the collecting ducts. Thiazides up in the distal tubule. Don't worry about acetazolamide at this point. Okay, so just another picture to give you where in the nephron these work, and then over at the side it tells you what electrolyte they're most likely going to affect. Okay, questions? All right, so let's move on to the ACE, ARBs, and the ARNIs. These are one of your foundational. So Objective 4 says, given a list of medicines that a patient with heart failure is on, identify what's missing. When you see a patient with heart failure, you ought to look down the list. As soon as I see what I'm looking at, okay, where's your heart failure regimen? And so as we're going through, you ought to know patients are needing to be on all of these. So you ought to be able to look and go, where's your beta blocker? Where's your furosemide? Where's your ACE inhibitor? Because they may have stopped taking them, or they've not been placed on them. So that's what that objective is referring to. This group of drugs is very powerful because it decreases morbidity and mortality. It decreases hospitalization, so it decreases the cost of care as well. The last sentence there is new with the newest update is that if you have patients stabilized, I've said it before, here it comes again. You have patients stabilized on an ACE or an ARB, still having symptoms, then the recommendation, as long as they're tolerating those two agents, no contraindications, no side effects, you can move them to an ARNI to increase the reduction in mortality and morbidity. We'll say it again as when we get to that group of drugs. ACE inhibitors. If it's got a pril on the end, it's an ACE inhibitor. Okay? So lisinopril, quinapril, ramipril, fosinapryl, enalapril, captopril. Captopril, first one in that group, that was released probably in the early 80s probably. Enalapril soon after it. Captopril had to be dosed multiple times a day. You'll see the rest of them usually either once or twice a day. The big studies were with enalapril in terms of morbidity and mortality and heart failure. So you'll see a lot of the recommendations, you go back to that one. Yeah, I don't think it's the one people tend to go to, but it certainly is a drug that will work. Lisinopril, a longer acting drug in the shorter duration trials, those have been effective as well, but your enalapril has the most evidence. But most of the studies are going to look at these as class effects, meaning if whatever you choose out of that class, you're going to get the effect that you want. So in heart failure patients, they lead to symptomatic improvement. They reduce hospitalizations, and they enhance survival. Okay. Mechanism of action. This is a long list. You do not have to memorize these, but I want you to see all the things that these drugs do. It's still not completely understood what they do, but they have multiple effects on the cardiac muscle. There is probably an activation of an intracardiac renin-angiotensin system, and they think that that is the cause of a lot of the problems in heart failure. So these drugs are able to ameliorate that response. They stabilize heart size. They prevent damaging remodeling of the heart. They improve endothelial function. They reduce concentrations of fibrinogen and von Willebrand factor. So that should mean something to you at this point, because those are heavily involved in what action?
Clotting.
Clotting, platelet activation. They decrease plasminogen activating inhibitor. What's plasminogen do? Converts plasminogen to plasmin. What's that do? Improves lung function because it has effects on the confusing capacity, diffusing capacity, alveolar capillary membrane diffusing capacity. For patients with hypertensive heart disease, they lead to regression of hypertrophy of the ventricle, improved diastolic function. They improve exercise tolerance and arterial compliance. So they're very important in this disease state. Okay, so lisinopril is just, it should stand in for ACE. Okay. So where does angiotensinogen come from? The liver. Anytime you see that ending, it tells you what? N-O-G-E-N. What's that tell you? What?
It's
the precursor.
Yeah.
It's a precursor to the active agent. So the kidney has enzymes that can convert that from angiotensinogen to angiotensin 1. So it's pronounced renin, not renin. What's renin? Casey. What's renin? You know?
Oh. Sorry.
It's what? It's cow. It's one of those parts of the cow.
Sorry, I was like,
sorry. So
Bye.
don't say renin. It's renin. So renin is with 2 N's. Renin is with 1. Renal, renin. All right.
Angina.
Angina. The only thing I'm telling you this is because you will sound more educated and people will go.
Not pharynx.
Okay, angiotensin 1 to angiotensin 2 converted by ACE, right? Where's the majority of that ACE? Lungs, about 70% of it, but it's in most tissues, have that capability. Angiotensinogen has 2 different receptor types that it can interact with. The one we like to knock out is AT1 because it produces the hypertension and vasoconstriction. AT2 leads to vasodilation when angiotensin 2 interacts with it. And then we get aldosterone, which comes from where? Adrenal cortex, okay? And it's a mineralocorticoid, which means what? It's a steroid base that affects what? Sodium, right.
Salty.
So this is the system that we are going to interfere with. Under indications, reduce morbidity and mortality, reduce death, increase survival. Here is enalapril. So you've got on the y-axis you have death or heart failure percent, and on the y-axis or x-axis you have years. So if you're looking at enalapril over the years, you have a great reduction, you have a significant reduction in death or heart failure with that drug being on board. So that's people who are asymptomatic, who have left ventricular dysfunction. So a diabetic. ACE inhibitor improves survival in moderate heart failure. Again, Here's your mortality percent, and here's your years out. So on placebo, what's the mortality percent? 40 to 50% at 4 years. What does enalapril reduce it to?
36, 37.
Here's an advanced heart failure. Impressive. What's the 12-year? At 12 years, what in people in the oral placebo were what?
65.
Almost 60%. Over 60%. And enalapril, what do you see?
45? 40, no, almost 50.
ACE inhibitors are important. They improve survival. Okay. And across the board, from asymptomatic to the advanced. So looking on page 14, patients should not be given ACE inhibitor if they've had a life-threatening adverse reaction. So that's angioedema. We'll talk about that a little bit more. Pregnant or plan to become pregnant. Use it with caution if people already have low blood pressure. So systolic less than 90. I saw another place that listed systolic less than 80. I went with the more conservative. Marked increases in level of creatinine. So ACE inhibitors usually will worsen serum creatinine. They'll almost always cause it to rise, and I'll show you why in just a minute. Bilateral renal artery stenosis. Their blood pressure will nosedive. Elevated levels of serum potassium. These drugs will always raise it. Always be careful. Anytime I see somebody on an ACE inhibitor, potassium supplements, an ARB, I'm always looking at, or an aldosterone antagonist, I'm always looking at the rest of their drugs. What else raises potassium? Prescribed to all patients with reduced ejection fraction heart failure. The benefits of ACE inhibitors is considered to be a class effect, so it doesn't matter which one you use in that group. They're always used together with a beta blocker. We start the ACE inhibitor first because its effects are faster. And once we get up to about a moderate dose, we will add the beta blocker, titrate it to max, and then further increase in the ACE inhibitor. Now, that's the way the guidelines recommend it. The other is that we shoot to increase that ACE inhibitor to the maximum recommended amount based on what happened in the studies, because that's where survival was the greatest. So usually with lisinopril, which is commonly used, we'll recommend titrate it up to 40. If they can tolerate it, regardless of regardless of the improvement along the way, your target is still 40 if they can tolerate it. So that would be different, because a lot of times we'll say, use the minimal dose that gets the job done what you want, right? Here I'm telling you it's based on what the studies have found to be most, produce the greatest benefit. Advancing doses, usually about every 1 to 2 weeks. Start low, especially the older the person is. Monitoring. You're going to assess renal function. If their kidneys are going to crash, they will do it fast, usually within the first week. I don't see many people do this, but the recommendation is to check their creatinine within the first week and then about a month thereafter. Also, pay attention to serum potassium. Advise patients, don't stop the drug. Now here, it's not a withdrawal phenomenon. It's more the deterioration in heart failure. So their symptoms will appear more quickly. Okay, let's talk about adverse effects. Usually they're well tolerated unless these things show up. So ACE inhibitors cause a dry cough, fairly common, up to 20%. So a lot of people will develop it. I'm always particularly watching folks in the spring and in the fall, because folks will often think that they have allergies. And so they'll treat the allergy. They'll get an over-the-counter antihistamine. They'll get a cough syrup. But if it's a dry cough, usually it gets worse at night when they lay down, doesn't go away, and they're on an ACE inhibitor, it's almost always the ACE Women more than men. Usually starts early, but it can show up after months to years of using it. It will go away quickly, usually, within a week or two. It'll go back to normal. If you try a different ACE inhibitor, it will come back. It's a class effect, so it pretty much, you won't be able to use that. So why is it that that happens? Let's see. We'll get to that. I'm going to do it under Angie's. So it's thought that it's the increase in bradykinins that lead to that cough. And so an antihistamine is not going to do anything for that. So if they're telling you the cough gets no better when I take an antihistamine or a cough suppressant, it's a pretty good indication, again, that it's the ACE inhibitor. Okay. Treatment, take them off, switch them to an ARB. ARBs have very low rate of dry cough. So usually they'll tolerate the ARBs over the ACE inhibitors. Next is hyperkalemia. So hyperkalemia, very common. Usually the ACE inhibitors will cause the potassium to go up by about a half milliequivalent per liter. It's because you have you've knocked out that aldosterone in the in angiotensin II. So your ability to excrete that by the kidneys has gone down. You've interfered with that. So the serum potassium levels are going to go up. This is more likely to happen in people who have renal insufficiency, diabetics. People are on other potassium promoting drugs. So if they're on a potassium supplement, be very careful. If you put them on an aldosterone receptor antagonist, be very careful. You have to monitor those potassium. So what's the problem with having potassium above 5? It's arrhythmogenic. So really concerned about 5.5. So what does it do to the EKG? T waves, right. Concurrent use of non-steroidal anti-inflammatories. They will work against your ACE inhibitors. They will, you may not be able to call them a failure, but you will not get the same response. Let's see. Questions on those? Okay, let's look at reduction in renal failure. Or in renal function. Okay, so here's Bowman's capsule. So this is the interface between the vascular system and the kidneys, is this unit called Bowman's capsule. You're familiar with it? You've heard about that. Okay. So you have arterioles coming in, form a capillary bed, and then you have arteriole leaving. So you have afferents. I remember you're just moving away from the aorta. Efferents are exiting the Bowman's capsule, however you want to remember. So that filtration is dependent on a pressure system. Okay? Think about having a filter, a bag that's got holes in it. If you squeeze that bag, what's going to happen to how fast it filters? Faster. What if you just let it hang there? Slow. Okay. So if you change the pressure in these arterioles, you will change the driving pressure in that Bowman's capsule. Okay. So if we give somebody an ACE inhibitor, we're going to decrease in that afferent arteriole. So the driving pressure in the Bowman's capsule goes down. So glomerular filtration rate goes down. The other thing the ACE inhibitors do is that angiotensin II exerts its effect here in the efferent. So that vasoconstriction will keep that driving pressure here high. You knock out the angiotensin II, the driving pressure goes down. So their ability to filter goes down. Serum creatinine doesn't get filtered as much, it goes up. Okay? So it's the effect of the ACE inhibitors on, and what in other, in the renin-angiotensin system, it's these effects that cause that decrease in renal function. It can occur fairly quickly. Okay. 3 to 5 days. So usually within, I've seen people crashing on a day that have been in the hospital, but usually within that first week. If you cannot control the potassium, or the serum creatinine rises to, this says more than 30% baseline, then you may need to consider moving to a different drug. Like, you can look at an ARB, but ARBs will do similar. If the person is, so such a decline in renal function is uncommon if the person's not volume depleted. Diuretics have transiently been withheld prior to initiation. They don't have bilateral renal vascular disease. Let me back up on that one. So when you start an ACE inhibitor, you have to be cognizant of what is their volume status. So most of the time we talk about if they're volume overload, we're going to put them on a diuretic, and then we're going to add an ACE inhibitor pretty quickly. You have to be careful. So we're going to use very small doses of ACE inhibitor to start, because otherwise they will have an exaggerated response and it'll get hypotensive. When Captopril first came out, what we would do is we would start it in the office. We would keep them in the office for 2 hours. We'd check their blood pressure before, we'd give them the dose, and then we would check them every half hour just to make sure that they didn't have a big hypotensive effect. We found for the most part people didn't. So what I do, if I'm starting it on an outpatient basis and they're on a diuretic, you could withhold the diuretic for a few days. Now, in this situation, that might not be a good idea. Or I'll have them liberalize their salt intake to keep them from having an acute reaction. So status, fluid status, when you start an ACE inhibitor is important. Question about that? So hypotension is, what's under here is kind of alluded to already. Excessive reduction in blood pressure can occur in the first dose. Minimized by don't start it if they're volume depleted. Stop the diuretic if you can. Liberalize their salt if that's an option. Start at very low doses. Question about that? Okay, angioedema. Probably talked about this. Yes, y'all had some. So there's a man who's come into the emergency room with it. Leading cause of drug-induced angioedema is ACE inhibitors. More common in African Americans. I would say in the diabetic clinic I saw, I bet you at least 20% of our African Americans had angioedema to ACE inhibitors. Can be life-threatening, so if they have it, avoid it. What's the mechanism? Well, it's those pesky bradykinins again. So bradykinins are activated by the clotting cascade, factor 12. And it causes a conformational change in a protein that releases these bradykinins. That's what's going through each of these steps. When a bradykinin works on the vasculature, it leads to permeability and an exit of fluid, an exudate. So they get these, usually it's in the lips, it can be the tongue, it can be their throat, they can have serious breathing problems, they can need ventilation support. If you look at the next page, angioedema can be divided into 2 groups. The first one is a hypersensitivity reaction. This would be due to like insect bites, foods, some other drugs than ACE inhibitors. It's fast. It usually has other constitutional symptoms, so they're itchy, they have hives. These respond well to steroids, epinephrine, antihistamines. The non-allergic angioedema, so there's a hereditary angioedema that is not allergic. ACE inhibitors fall into this. This is why they do not respond to glucocorticoids, antihistamines, or epinephrine. So the swelling can occur very quickly, within minutes to hours. It takes a while to resolve. Most people will have mild. Some people will resolve on their own. But they do need to be watched because they can have life-threatening airway problems. You're not going to give them antihistamine, steroids, or epinephrine. So what do? You airway manage, airway support if needed. You stop the ACE inhibitors. And under that, and they should resolve within about 3 or 4 days. At the very bottom of that, under that discontinue ACE inhibitors, they should never, ever again be put on an ACE inhibitor. You know that Taylor Swift song? We are never, ever, ever getting back together. We're never, ever putting him on this drug again.
I have no idea what that song is.
You have no, somebody play that for you. You gotta watch the video, because that's okay. Okay, so there is a drug that came out about 5 years ago. The one at the bottom, the Cativan, or Firazyr. It is a selective bradykinin B2 receptor antagonist. It is intended for, or used for, hereditary angioedema. It does have an off-label use for angioedema due to ACE inhibitors. It is extremely expensive. You look at the bottom, it's what, $12,000 per one dose, and usually you have to give 2 doses to an ACE inhibitor. Usually you give one, they don't have a complete response in 6 hours, you can repeat. So you are only going to do this when you've got somebody who is probably going to have to go on a ventilator. So a ventilator plus an ICU stay is going to be more than $30,000, or more than $12,000.
Does insurance cover it?
A couple of years ago I said no, I don't know now. Sometimes as those come along they will, because they will save money. You can keep them off the ventilator and keep them out of the ICU, that would save them money. Okay, questions about those? So let's talk about the ARBs. You'll see in some of these places I'm referring you back to material we've already given you, either Dr. Britton or myself. Okay, same system, different spot. So here we're trying to block out the type 1 receptor. That's the one that will, if angiotensin II sits on it, will cause vasoconstriction. So we're going to knock out that receptor. These are considered second to if they can't use an ACE. Okay? So you would go for an ACE inhibitor. If they can't tolerate it, they have side effects, contraindications, you can use an ARB. They can reduce morbidity and mortality as well. You're going to use them with a beta blocker just like you would with the ACE inhibitor. You will occasionally see recommendations or people talk about using an ACE and an ARB together because you're working at different places in that system. Do not do that. It's okay for a specialist, but you really have to be careful. The interaction is too great and the effect is powerful. So never do that just on a routine basis. Reduced hospitalization, mortality also have been demonstrated with the ARBs. If someone's had an angioedema, that's tricky. The probability that somebody will have angioedema on an ARB that headed to an ACE is low. I'd say if they've had mild, you might consider it. But you have to be careful because they can also get angioedema to that. The other is if you have an annoying cough or those ACE-induced coughs, ARBs are very unlikely to do that. So those are two places where you could use an ARB instead of an ACE inhibitor. Monitoring parameters, same. Risk of hyperkalemia, same. Pregnancy, still contraindicated. The angioedema is listed there. You have to take into account what the risk is. Renal function problems, the same. So pretty much what you've learned for one will also apply to the other. Let's see. Okay, that's pretty much those. Questions about the ARBs? So ARNI, the angiotensin receptor and the neprilysin inhibitors. So here they have combined valsartan, which is the ARB, with the neprilysin inhibitor, which is the Kubitril. If you watch TV, which I'm sure all of you do, the Nestro, Entresto, they have commercials for it all the time. That's this drug. You're always talking about a heart failure patient. They're all showing a grandfather and a child and the disappointment when the grandfather can't play with the child.
Oh, yeah.
And they take Entresto and they can play. They can go to the zoo, they can get on the jungle gym. That's this drug. So neprilysin is a neutral endopeptidase. It neutralizes the effects of like natriuretic vasoactive peptides. By doing that, it decreases vasoconstriction, edema, other maladaptive changes in the heart. So this is a very powerful combination. This drug has been around probably less than 5 years. What the studies are showing are very promising. Here is where they're saying that if you've got people on ACE or ARB and they tolerate it, but you need more effect, you can switch them to an ARB. In one of the studies, there was a 20% effect on morbidity and mortality, positive effect, over and above what the ACE and the ARBs had. So indicated for class 2 and class 4 heart failure. So you're not going to use it. It's not going to be your starting point. You would not use it in your stage 1 or class 1s. Contraindications, angioedema. So you got that ARB in there, you got to think about that. So what has been the effect in the past? Do not use it with an ACE inhibitor. So you got to separate it out, at least a 36-hour washout between stopping the ACE and starting this combination. Let's see. For the most part, everything else in terms of monitoring parameters and contraindications and adverse effects are all going to be the same for each of those classes. Okay? Beta blockers. So go back and look what I've given you on beta blockers in the antiarrhythmics, what Dr. Britton's given you also in the hypertension lectures.
Do we do beta blockers?
Yes, yes. So beta blockers, every patient's going to be on a beta blocker unless there's a reason not to. There are only 3 beta blockers that have been shown to have decreases in morbidity and mortality. So these are the 3 we use. So we're not going to tap into the whole class. We're going to use these 3. Bisoprolol, I would say, is probably the least of the ones used. Carvedilol, very commonly used. Corig is the brand name. And the extended release metoprolol succinate. Here's that salt. It's the extended. Remember, what's the salt for the immediate release? Tartrate. Metoprolol tartrate's not what we would use here, so the extended form is the succinate salt. Toprol XL is the brand name. We're going to start these agents as soon as we can. So we're going to start we're going to take the volume off, excess volume. We're going to diurese them first. We're going to start an ACE inhibitor, and then we're going to start a beta blocker in pretty close succession. Beta blockers can reduce the risk of disease progression. Yay, that's good. Remember those falling lines to mortality? clinical deterioration, sudden death, because they have those antiarrhythmic effects. They have all those good effects on the heart. They're also the one drug that's going to affect the sympathetic nervous system. Remember, when we have that constant stimulation of the sympathetic nervous system, what do the beta receptors do? Downregulate. So we give them beta blockers, what happens to the beta receptors? They upregulate, yay, so the resistance goes away, and we get good benefits there. Okay. Reduces death, combined risk of death or hospitalization. Good stuff. Contraindications, the very same that you learned for antiarrhythmics, which I know you all still remember. The very same. Administration, we're always going to use it with a diuretic. You go back and look at when we talked about antiarrhythmics, the one thing that leads to deterioration of cardiac function is volume overload. So it tells you, first take care of the volume problem, then start the beta blocker. Keeping them at a drier weight will also keep them from decompensating. ACE inhibitors usually start at first, then the beta blocker. Start at low doses and we'll titrate up to maximum effect. You can still use them in reactive airway disease patients, just got to be careful. Because at the lower doses, we get what out of the beta blockers? What's their cardioselectivity at low versus high? Better. Beta 1 better at low doses, lose it at the higher doses. Okay. Monitoring parameters can be saying blood pressure, heart rate, rhythm. Potential adverse effects. These are very similar to what I gave you in the antiarrhythmics. So decompensated heart failure can be a problem. It usually isn't a reason to stop the drug. You diurese the person, get them on a stable dose of diuretic, and usually the beta blocker continues. Here's a good one under number 3. So what we will commonly do to avoid them taking all their drugs at one time that can cause hypotension is we'll have them take the ACE inhibitors in the morning, take it once a day, and beta blockers at night. That usually will help. The beta blockers, because you get that rise of catecholamines overnight, the beta blockers will help with that. So we're going to separate those out if we're using once a day drugs. If you're using twice a day, Coreg is often twice a day. Usually that ACE inhibitor will have maximum hypotensive effects about 2 hours after the patient takes them. So you might have to adjust and move them around as to when they take those if they're having to take a twice a day beta blocker. Fatigue. It's the hardest one of the group to address because it has multiple other factors. At the very end, there is the new recommendations are looking at comorbidities. And so one of the recommendations out of the 2017 guidelines is address anemia. And they recommend using IV iron to address anemia so that is not contributing. Sleep apnea can certainly be a problem. Depression. When you get to the psych, Dr. Britton will talk a lot about depression with chronic disease. It's very common. You got to look for it because those patients are dealing with things that are lifelong, never leave them. And so sometimes their ability to cope is not as good as or as well as we would hope or that they can tolerate. So addressing that is important. Okay, what I'm going to do is I'm going to stop here, and since there's 2 hours blocked out for the midterm tomorrow, I'm going to finish this up at 10 o'clock, then I'll have you guys exit, I'll get the room ready, and then we'll have the test, since we've got that blocked out, instead of jamming the rest of it. Any questions? All right, great, thank you, good luck.
EKG?
I'll see you at 10 tomorrow.